Just to introduce Dr. Foltz, I'm sure most of you know who she is. She's co-head of St. Paul's Hospital Division of Hematology and chair of the BC Cancer Myeloid Tumor Group. Her area of special interest is myeloproliferative neoplasms, MPNs, and she is principal investigator for MPN clinical trials and the executive member of the Canadian MPN Group. And obviously, she's my hematologist and my doctor, so I'm very proud to have her here. And welcome, Dr. Foltz, and I turn it over to you.
Thanks, Mark. Thanks for inviting me. I love to come to talk to the patient group. It's been a number of years since I've done it actually, so it's been too long. So we'll try to maybe keep it on a little shorter interval if it's helpful for people, because it is a good way to connect. So I do, of course, know many of you, and my apologies. I haven't looked through all the lists. So if I don't, when I see you at the appointment, if I don't remember that you were here, please let me know because I didn't scan everyone's name. But for those of you who don't know me, as Mark said, I'm a hematologist. I work at St. Paul's and I've got a special interest in MPN. So this is kind of my thing. So and thank you to everyone for submitting your questions ahead of time. So Mark sent me the list, and what I've tried to do is incorporate them as best I can into the talk. But if I missed anything, or if you think of something during the talk, or if you didn't get a chance to submit your questions to Mark, then you can put it in the chat as we go along, or if there's time, we can talk a bit at the end as well. As is usual for these types of presentations, I can't, of course, give like specific medical advice for your individual situation because there's a lot of things that go into it, but I'm happy to answer more general questions about the myeloproliferative neoplasms. Other thing I should say is it is MPNs are it's quite a broad category. So we've got ET, PV, and myelofibrosis. And so I'm going to try to do my best to touch on everything. But because I'm touching on everything, I won't be able to go into any one of those in a lot of detail. But hopefully, I'll be able to address some of the questions that have come up. Yeah, so I'm going to try to give a bit of an overview on the myeloproliferative neoplasms. With the myeloproliferative neoplasms, I'm referring to the three conditions, so essential thrombocythemia, polycythemia vera, and myelofibrosis. And all of them are related in that people can start with ET, and then most commonly it just stays as ET, but sometimes it can progress if a person's JAK2 positive to PV. And sometimes ET and PV can both progress to myelofibrosis, although fortunately not that common. So for most people, it just stays steady as ET or PV, but there is that risk of progression and it links these diseases. With all of these conditions, there unfortunately is also a risk of progression to leukemia. Again, pretty rare for it to happen directly from ET or PV, but occasionally can happen, and it is a concern with higher risk myelofibrosis. So this is kind of what ties these diseases together, is that they can move between each other. So you can start with one, but over the course of a lifetime, there can be shifts or changes. The other thing that ties these diseases together is the mutations. So with all of the myeloproliferative neoplasms, there is activation of this JAK2 signaling pathway. So this is my picture of a cell. So this is the membrane of the cell, and there's a receptor here, and then there's a signaling pathway of proteins within the cell that affects the expression of genes from the DNA. And in everyone who has an MPN, there's increased activity of this JAK2 signaling pathway. But there's different mutations that can drive this, or different reasons why it can occur. So in general, most people have one of these three driver mutations. The most common is a mutation in JAK2, so the JAK2 protein itself, which makes this signaling pathway overactive. And this is the mutation that's almost the only mutation that's seen in polycythemia vera, and about half of people with ET or myelofibrosis have this JAK2 mutation. In people who don't have the JAK2 mutation, they have increased signaling through other mechanisms. And the next most common is the CALR mutation. And the CALR protein, when it's mutated, binds this whoops, I'm going to go back, binds this receptor and causes the signaling. And then the least common mutation is a mutation in this receptor itself called MPL. And I mention this again because it's kind of what unites all of these, the myeloproliferative neoplasms. And it is important when we're talking about the newer types of treatments and how they work. One of the most common questions I get is this something that runs in the family? People understandably concerned, of course, whether other family members might be affected. And for most people, there aren't other family members that are affected. It just occurs in an individual. But there are some cases where there can be other family members. Now, it's important to know that the mutations we talk about in MPN are not directly inherited. So when we're talking about these JAK2 mutations, the CALR mutations, these are mutations that are acquired at some point later in life as an adult. So you wouldn't be born with them, and they're acquired in adulthood and only in the blood cells. So if we checked other cells in a person's body, like their skin or their hair or their liver, their lungs, there would not be these JAK2 or CALR mutations. It's only in the blood cells. And likewise, it's not in your sperm or ovaries, so you wouldn't be passing it on to any children and you wouldn't have directly inherited it from parents. However, it does seem that there are some families that can be predisposed to acquire the JAK2 mutation at some point in their life. Now, in these families, again, most people don't get it, but there seems to be an increased risk in some families due to genetics of the base gene for the JAK2, where the mutation develops. And there's still more research that needs to be going on with this. If anyone is concerned about family members, the thing to do, we don't have genetic testing that we can do for this. It would just be to get the blood checked to see if the blood levels are elevated or normal. If the blood levels are normal, there wouldn't be any further testing that would need to be done. I also got some questions about, I think can everyone just double check that they're muted? Because I'm getting a little bit of background noise from somewhere. So if you could just double check, that'd be great. The other questions I get are about the diagnosis of the myeloproliferative neoplasms. And one of the questions I got was, do I need a bone marrow? And the answer is, it depends. For myelofibrosis, we always need a bone marrow. So bone marrow is needed for the diagnosis. For ET and polycythemia vera, to have an official diagnosis by the WHO criteria, the World Health Organization criteria, then yes, you do need a bone marrow for ET and for most PV. So they have an exception for PV if someone's hemoglobin is really, really high, then that is sufficient. But for the most part, it is required for an official WHO diagnosis. Now, that being said, a lot of hematologists do shortcut this in the right circumstances. So if the JAK2 test is positive and everything on the blood tests and the clinical presentation is very consistent with ET or PV, then some hematologists, myself included, in certain situations won't necessarily strongly recommend the bone marrow or may not, even suggest the bone marrow if it seems really clear what the diagnosis is. The other kind of special situation in BC is that if someone doesn't have the JAK2 mutation, then we do need to check for CALR and MPL we want to try to confirm the mutations in MPN. And in BC, we need to do a bone marrow to get the sample to check for CALR and MPL. This isn't true like in other provinces. They will test this on the peripheral blood, and it is likely in BC within the next year we'll have peripheral blood testing for this too. The reason to think about a bone marrow is that it can more definitively clarify the subtype of NPN. Now, most times it's not a big question because with ET, the platelets are high. With polycythemia vera, the hemoglobin and hematocrit are high, and the platelets and white blood may also be, but it's primarily the hemoglobin and hematocrit. So usually it's not a mystery, but sometimes people can have borderline values with between ET and PV where the hemoglobin and hematocrit's a little bit high, but not too high. So the bone marrow can help clarify that, which can be important for whether we're because with PV, we focus a lot on the hematocrit, and ET, we focus more on platelets. So knowing which we're treating can be important there. And then the other one is for distinguishing between ET and pre-fibrotic myelofibrosis, which is the really early stage of myelofibrosis. And this wouldn't change the treatment, but it would change the, prognosis in terms of what to expect, because if someone has pre-fibrotic MF, they're more likely to progress to overt MF in their lifetime than someone who has ET. So that's why that would be the consideration if it was important to distinguish that. Okay, let's move on to what's what I call the clinical manifestations, or like what people might experience with MPN. And I group them into three main categories. So thrombosis and bleeding, symptoms related to MPN, and that includes enlargement of the spleen, and then this risk of progression to myelofibrosis or leukemia. And these are the things that we're trying to address if we can when we're thinking about treatment and monitoring for MPN. So everyone here is probably really aware of the symptoms that can come with MPN, and I think there is more recognition over time in the medical community of the symptoms associated with this. Fatigue is by far and away the most common symptom that we see. So this chart is for myelofibrosis, but with ET and PV, people experience the same symptoms, just sometimes in different prevalence and different amounts, but it's the same symptoms that people can experience with all three of the MPN. So this is from this MPN system assessment or symptom assessment form, which was developed partly for clinical trials to be able to objectively describe if symptoms are getting better with treatments, but it also can be a really helpful measure of just the burden of symptoms that people are experiencing. So these are the ones on the list, but of course there are more that people experience. Managing the symptoms can be one of the biggest challenges in MPN because we have some strategies to manage them, but unfortunately our strategies aren't completely effective for all of the symptoms, and there's some symptoms we do better with than others. The itch can be a really troublesome symptom. So, of course, more common after a water exposure, bath or shower. And when we think about managing it, a part of it is trying to identify triggers and avoiding triggers, but some you can't, and finding strategies that work well for a person as an individual. And it's different between different people. So some people tell me cold showers are better. Some people say warm showers are better. Some people like warmer environments. Some people find it better in the cold when they're not perspiring as much. So it's really very individualized and trying to find what works for you. In terms of medications for the itch, it's the like creams don't usually tend to work because it's not an itch from a rash, it's an itch from within. So the medicines we try are antihistamines. Someone asked a question as to whether we can measure histamine levels. It's hard to do. We do measure histamine levels in the urine for other blood conditions, one called mastocytosis or mast cell activation syndrome, where that's important to make the diagnosis. If someone already has a diagnosis of NPN, measuring histamine levels wouldn't really give much added information because we already kind of know why the itch is there. And in terms of treating with antihistamines, it's a bit of like trial and error, just trying different ones and seeing if they work or are effective. Um, For really refractory itch, sometimes low doses of the antidepressant medication called Paxil or paroxetine, one of these SSRI classes, sometimes that can be helpful as well. And then it's also, wouldn't usually start a what we call a cytoreductive or an NPN treatment. We wouldn't commonly need to start it for itch alone, but itch in combination with other things would be something that might push us towards considering treatment. And I'll talk about the different medications and which ones work better for itch. But to some extent, all of the hydroxyurea, interferon, ruxolitinib can all be helpful for itch. Headache can be problematic, and often low dose aspirin can help. Erythromelalgia is the other unique one, which is like the burning sensation in the fingers and toes. And this often responds really well to low dose aspirin, although sometimes people require aspirin twice a day, like 81 milligrams in the morning and 81 at night, or a double dose if the erythromelalgia is really bad. There's weight loss, this early satiety, so feeling full soon, which is with a small meal, and that's often because the spleen is enlarged and pushing on the stomach. Night sweats and enlarged spleen. So with these ones, there's some strategies that we can employ, like for early satiety, it would be eating small meals frequently can be helpful. And then for people experiencing weight loss, just trying to be mindful of caloric intake, taking supplements like Ensure, Boost, nutritional supplements. And again, if you can't eat a big meal, eating small meals more often. And the medications I'll talk about can be helpful, particularly for these, what we call constitutional symptoms and the enlarged spleen. The most troublesome symptoms are the next group I have listed, this fatigue, this brain fog, difficulty with concentration. And by troublesome, I mean because there isn't a treatment that works really well, unfortunately, for addressing them. So, we always hope that maybe our medications will be helpful, and sometimes they are, but a lot of times, unfortunately, people continue to have ongoing difficulty with that even when they start a medication for NPN. So it does sometimes require just adjustment of what you're doing in the day, pacing yourself, and having ways to manage it. I had a question about bone pain. So bone pain is a feature of the NPN. It's more common in myelofibrosis, but occasionally can occur in polycythemia vera and ET. And it relates to the bone marrow being abnormal and leading to pain in the extremity. So it's usually in the long bones of the legs, so like the upper legs and sometimes the upper arms. Um, the medication, pain medicines like Tylenol is usually what we would recommend initially. And sometimes it can get better with hydroxyurea, interferon, ruxolitinib, these cytoreductive medications. But again, it's variable between people. The question I got more related to a bone lesion, and the bone lesions are less common. Sometimes there can be bony lesion from like collection of blood cells, the bone marrow cells in certain areas, but we don't usually see like bone damage like we would in breast cancer, prostate cancer, and other kind of cancers that have spread to the bone, or other blood cancers of the bone. So it's tough to know. I think that would be like a special situation. I also got a question about symptoms in toes, and sometimes this can be gout. So, gout is more common with NPN due to the turnover of the blood cells. And for people who have gout, it's just usual treatment of gout treatment. Erythromelalgia can cause a burning sensation in the toes, and that we would usually treat with aspirin. And then toe symptoms can sometimes be a side effect of hydroxyurea, where people can get ulcers or sores, usually on the leg, but sometimes on the toes. But neuropathy, so nerve damage or a painful burning sensation related to the nerves without the redness of erythromelalgia, that's not a common or usual feature of NPN or a side effect of the medications with the exception of this new one, momelotinib. So it's not clear if that would be related. Okay, so in addition, of course, to wanting to do what we can to optimize symptoms, then the other important factor is to reduce the risk of thrombosis. So we know with all of the NPN, there is an increased risk of blood clots. So it can be blood clots in the veins causing painful swollen legs, heart attacks, strokes, blood clots in the arteries. And that's one of the biggest reasons we offer treatment in ET or PV to try to reduce this risk. So these are the risk factors for blood clots. We also have this scoring system for ET for risk of thrombosis that incorporates this factor. So basically these ones are things that increase your risk. Most of them you can't change. So previous thrombosis, age, mutation. The only one that we can change is these cardiovascular risk factors. So that's smoking cessation, making sure blood pressure and cholesterol are under good control, and that diabetes blood sugars are well controlled. There aren't specific guidelines that I'm aware of for, I mean, there's some general guidelines, but usually it's not that different for NPN than for regular guidelines for management of cholesterol and diabetes and blood pressure, although acknowledging that you are in a bit of a higher risk category. So we want to be a little more vigilant, about the treatment of these cardiovascular risk factors. The data, though, I got a question about the use of statins. So I haven't seen any specific statin data for NPN. So it would just be extrapolated from other populations and using sort of similar lipid treatment targets that we would use otherwise. So the treatments that we have to reduce the risk of thrombosis are aspirin, which I'll come back to, the anticoagulant. So this is stronger blood thinners in people who've had a previous blood clot before. So we wouldn't use it preventatively. It's just a previous blood clot, managing cardiovascular risk and keeping the hematocrit controlled. And I'll come back to some of this. And then finally, the other thing that we would like to do with treatment and management when we can is to reduce the risk of disease progression. But this is hard to do, and there isn't good data for most of the treatments to know if this is the case. There's some thought that maybe interferon might reduce the risk of progression. I'll talk about this a bit later. And then also, one of the things that's emerging is this, what we call allele burden. So allele burden is measuring the amount of mutated gene that you have. So we can measure this for JAK2, what this allele burden is, and for CALR as well. In research studies, we can measure like how many of your blood cells have the mutation. And then the idea is that a treatment that suppresses that, in theory, should be good, suppressing these abnormal cells. And it is something that is measured in clinical trials, and it is measured at some of the larger centers in the US. Unfortunately, it's not something that we have routine access to here in Canada, and it's not really it's still being researched how the correlation between reduction of allele burden and long-term outcomes. So there's some data to suggest that, it's a good thing for long-term outcomes, but other data, that link hasn't been as clear. So it is in some ways still a research tool, although that being said, they do use it at some centers in the States. But even when I've asked the doctors from MD Anderson, they're not like monitoring it and adjusting their medications based on allele burden for the most part outside of a clinical trial. With myelofibrosis, we want to reduce the risk of progression to leukemia for higher risk situations. And the only treatment we have that can do that is a stem cell, or also called a bone marrow transplant. This is the only potentially curative therapy. The problem is that there are unfortunately a lot of risks associated with this procedure too. And so it's always an individualized decision. And I'll come back to that too. Okay, so to summarize for management of ET, it's based primarily on the risk of thrombosis because that's the biggest treatment goal that we know our treatments can do is reduce the risk of thrombosis. So that's what we're aiming to do. So we group people into lower risk or higher risk. So we can use this historical scoring system or this newer IPSID score. And in people who have low risk disease, who are don't have a lot of symptoms, we can monitor, but people with higher risk disease or with low risk disease who have a lot of symptoms, very high platelet count or a white count that's really rising, then we would consider treatment with a cytoreductive agent. This high platelets, it's different, you get different opinions on that. So I wouldn't say it's an absolute, but the concern is when the platelets are really high, there is some increased risk of bleeding. But if a person is not having bleeding, it's not a definite for me. So for most people, except the really low risk, I do suggest the ASA 81 milligrams. And then for people who are higher risk or have these other features, we consider treatment with a cytoreductive treatment. The first line treatment in BC is hydroxyurea, although interferon is also a very acceptable first line treatment. In BC, interferon's only funded if you've tried hydroxyurea and can't tolerate it or it doesn't work. And in second line, we would use, so this is if hydroxyurea has side effects or doesn't work, then we have interferon or anagrelide, which is not as commonly used. And I'll talk a little more about the medication shortly. Oops, sorry. For polycythemia vera, it's actually very similar. So we have the low risk and high risk of thrombosis. So everyone with polycythemia vera, we want to keep the hematocrit under 0.45. So we would use phlebotomy initially to do that. And for everyone with PV, unless they have a reason they can't take it, we recommend aspirin because there's good data to say that reduces the risk of blood clotting. And then in people who are at higher risk of blood clotting or one of these special situations or having more symptoms, then we would consider again these cytoreductive treatments. And it's the same situation. Interferon and hydroxyurea are both good options in the first line setting, but hydroxyurea is the only one that's funded. And then in the second line, we can either use interferon or for polycythemia vera, ruxolitinib, which I'll talk about as well. So we don't have ruxolitinib available for ET. It's just for PV and myelofibrosis. And we usually don't recommend iron supplements, especially if it's just using phlebotomy because it can drive up the hematocrit. But there are situations where we do give them, so it's under the direction of your doctor. Okay, I'm going to talk a little bit more about the specifics of treatments that we use for ET and PV. So for PV, one of the initial treatments we usually use is phlebotomy, so the bloodletting. The benefit is it quickly reduces the hematocrit, so it can bring things down rapidly, and you don't need a medication. The challenges with phlebotomy long term are iron deficiency. So, just how it works, there's iron in each bag of blood. And so, over time, people will become iron deficient. And if we're only using phlebotomy, we can't replace the iron, or the hemoglobin will just go up again. So, can have symptoms of iron deficiency. For some people, it can be inconvenient going into the hospital. The phlebotomy doesn't lower the white cells or the platelets, just the hematocrit. So it just controls part of the blood counts. It doesn't reduce the spleen size. So if that's bothering you, then it doesn't help. And it absolutely reduces the risk of blood clotting, but not quite as much as some of the other treatments. So for higher risk people, we'd be recommending a medication too. And by higher risk, I mean higher risk of blood clotting. Hydroxyurea is a really commonly used medication. The benefits are it reduces all of the blood counts, so it'll bring down the white, the red, and the platelets. It does cause the red cells to become bigger. So on your blood test report, this will show up as an increased MCV, which is the size of the red cells, or sometimes you can get descriptions where it says the red cells have macrocytosis, which just means they're bigger. This is just how the hydroxyurea works. So what it does is it slows down the blood cells. It inhibits the blood cell division in the bone marrow. So the blood cells, because they're not dividing as much, they end up growing a little bit larger. So this macrocytosis, which someone asked about, is just an expected finding with hydroxyurea. It's not of concern. It's just it's expected. Hydroxyurea can reduce the spleen size. It can help with some of the symptoms, and we know it reduces the risk of thrombosis and bleeding. Good things are it's pretty well tolerated. It does have some side effects, so it can cause mouth sores, skin changes, occasionally can cause leg ulcers. I mention that because sometimes, if I'm not seeing a person all the time, if I don't see them for a number of months, and then they could have a leg ulcer and not realize that it might be related to the hydroxyurea. One of the long-term risks is skin cancers, so not melanoma, the most serious, but these squamous and basal cells. So if anyone on hydroxyurea has any growths or changes in the skin, need to get that checked out because it might need to be removed. And then another challenge is it lowers all of the blood counts. Now, in some ways, that's good because if everything's high, it lowers it down. But sometimes we have the situation where, say, the platelets are high and the dose of hydroxyurea we need to lower the platelets causes the hemoglobin to go too low and makes a person more tired. So that getting the right balance can be difficult. The second medication that is considered is one called interferon. And this type of interferon we have now is called PEG interferon, which is a longer acting interferon that has less side effects. And it can be used for the treatment of ET or PV. Its benefits are it's not a chemotherapy, so that's something understandably likable about it. It lowers the blood counts, which is a good and a bad thing. So the same as with hydroxyurea, and it lowers them all, but sometimes too much. It reduces risk of thrombosis and bleeding, so that's good. It helps with some symptoms. It reduces spleen size, although probably not as well as hydroxyurea, but it's a bit individual. Some patients can have a reduction in this allele burden. So not everyone, but some patients can. And, we hope that the patients who have that reduction, that it leads to long-term benefits. And it's a difficult thing to study because interferons are really slow acting medications. So even when it's working well, it can take like 3 to 5 years before seeing benefits in the bone marrow or with the allele burden. And the challenge with it is that it can be difficult to tolerate, that I'll talk about in a second. But my general overall feeling with interferon is that if a person is able to tolerate it with manageable side effects and able to stay on it for long periods of time, and by long, I mean like 5 to 10 years, then there is some long-term data that person may benefit from some improvement in the bone marrow or in this allele burden situation. But it's not always the easiest medicine. But people who are on it, who are doing well on it, love it. So I find like people fall into two camps with interferon, that it's either going great and they love it, it's working really well, or there's other people that just have side effects and issues with it and can't take it. So it's and there are some people in the middle, but it's a bit of a polarizing medication. But I do use it. I like it too. Okay, so the challenge is it's slow acting, it's a subcutaneous injection, it's got more side effects on average than hydroxyurea, although they are all individual. So it's flu-like symptoms, rash, dry eyes, dry mouth, mood changes. Some people have exacerbation of depression. Some side effects can come up long term, so you can be okay at first, and then some immune-mediated side effect can come up later. And this liver inflammation, we always have to monitor liver enzymes because if there's too much liver inflammation, we have to cut back the dose. With the peg interferon, there are two forms of it. So Pegasus is the one that's available, well, sort of available in BC. So historically, it's been the one that's available in BC. It's been around longer. It's called peg interferon or interferon alpha 2A. And then Bezremi, this is a misprint. It's actually Ropeg interferon alpha 2B. So it's similar, but not the same. Pegasus is injected once a week, and Bezremi is every 2 weeks. Bezremi is available in Europe and the US. It is not yet approved by Health Canada. Bezremi has gone through some of the large studies. So in the US, it has the approval by the FDA specifically for polycythemia vera, whereas Pegasus is not officially approved, although it's widely used, but it's not officially approved. Even Bezremi is not approved anywhere for ET because most of the studies were done in PV. But that being said, it's widely used in ET as well. No one's compared Pegasus to Bezremi head to head. It's felt in general they work similarly well and the side effects are similar. And the big difference is injecting once a week versus every 2 weeks, although a lot of people with Pegasus end up injecting every 2 weeks. And the dosing numbers are different. So you can't just convert it directly because the dose range is different. I mention this because, as many of you are aware, there is an issue with the Pegasus supply right now. So the manufacturer of Pegasus is setting up a new manufacturing facility, which won't be open until the end of 2025. And so they're not making any more right now. And we're just going through the supply that was available stockpiled, and there is a limited supply and it is being distributed very slowly. So people are experiencing just getting like 1 week supply from the pharmacy. It seems likely there will be a ongoing trickle supply, but certainly not enough for any new people to start on Pegasus right now. And we are looking at ways for individuals to be able to minimize the amount that they're using. So there's some strategies, like just in general with Pegasus, a lot of times people who've been on it for some time, who are taking it once a week, can cut back to every second week. So if that's something that you and your doctor may have been considering anyway, now is a good time to do it and to give it a try, because often every second week dosing can still sustain the response. So we're trying to prolong the dosing interval. If there really was no supply, then it would be an individual decision whether to switch to an alternative medicine, depending on individual risk status, or whether it may be possible, if you were just on a low dose of Pegasus, to try taking a break and then just restarting something if the platelets or hematocrit start to grow up. So it really is kind of individual what to do. We are also trying to get a supply of Bezremi. Now, this is difficult because Bezremi is not approved by Health Canada, but Health Canada is, and thank you for those of you who have been contributing to the conversations with Health Canada, but Health Canada is looking at authorizing Bezremi in a shortage situation. So this is because there's no supply of Pegasus, kind of emergency situation. And it seems likely they will do that, but the wheels of government turn slowly. And so we do not have a timeline as to when this authorization may or may not come through. And then there also needs to be the logistic arrangements with the pharmaceutical company to bring the drug in, and then it has to be distributed and paid for by the government. So there are a number of steps in this process. It does seem promising that this is likely, but I just don't have any more details on timelines. So that may be an option if there is no Pegasus supply, for some people to transition to Bezremi, or for people who are just looking to start an interferon to just start with Bezremi instead. So that's kind of what we're thinking. And in terms of conversion, there will be some more, by the time Bezremi actually gets here, there will be more information available on how to convert or switch over. Okay, and finally, we have the medication ruxolitinib, which is available for people with polycythemia vera who can't tolerate hydroxyurea or are symptoms that are persistent with hydroxyurea. and for people with myelofibrosis, the benefits of ruxolitinib. So this is a JAK inhibitor. It is the best medication for symptoms and reducing spleen size. So people who have a lot of trouble with like weight loss, night sweats, itchiness, really big spleens, ruxolitinib or another JAK inhibitor is the best choice. It does lower all the blood counts and have these other potential benefits. The allele burden data isn't as robust as with interferon. Generally well tolerated. Side effects are shingles and this skin cancer risk. And to wrap up polycythemia vera as to what's coming in the future, the medication that is in clinical trials that's farthest along is this one called rusfertide, and it works on the iron pathway. So we have to think of this as like a pill that works kind of like phlebotomy. So what it does is it affects how iron is used so that the bone marrow doesn't have access to iron to make more red blood cells. But so it's good that you don't, what people on the study didn't need phlebotomies, but it doesn't work like, say, hydroxyurea does to bring down the white blood and the platelets. So this is really more like pill that does the does kind of like what phlebotomy does in terms of reducing the hematocrit. And we're still waiting on the data and for quality of life to see if people feel better on this medication than they do on phlebotomy. There's some early hopeful data, but we need to get more. Okay, shifting gears a bit, and I'm going to pick up the pace as I don't want to keep people too late. So myelofibrosis treatment, it's got some different principles than what we use for ET and PV. So with myelofibrosis, the treatments are all based on risk because people, well, the main treatment pathways are based on risk because people who have higher risk, we want to consider whether they're eligible for a stem cell transplant. And if they are, we consider a stem cell transplant because it's the only potentially curative therapy. For people who have lower risk disease or if transplant's not an option, then we have treatments to help with the symptoms. So to help with the spleen and the other symptoms and to help with the anemia. So one slide on transplant. So I'm not a transplanter for full disclosure, but I do refer people for transplant. So this is one of the most difficult decisions for many people and for many doctors is about the stem cell transplant and the timing of the stem cell transplant. So we're trying to weigh things out because of course it's got the benefit of, if all goes well, potentially being a curative option. But there are significant risks associated with the transplant itself. So to try to weigh out whether it's a right decision for an individual person and about the timing of if you are going to have that transplant, when's the right time? So this is all really tough. And so things that come into it are the risk of the disease. So how likely is it that the disease is going to progress and get worse over the next couple of years? And of course, if that's more likely to happen, then we'd be more favoring transplant, where if it seems like the disease is low risk and nothing's going to happen, then it wouldn't be worth taking the risk of transplant if you're going to be okay. So the risk of the disease and then the risk of the transplant, which are different for different people. And it depends on other health issues, comorbidities, and also if you have a donor and what type of donor you have. So there's lots of things that come into that. There have been a number of models, so research being done to try to answer this question as to when is the right time. And so just at the American Society of Hematology, the ASH meeting in December, there was a kind of a complex mathematical model that someone developed for this. But the bottom line is that, and again, it's different, there are a lot of individual circumstances, but if people have really high risk disease, then sooner rather than, and the risk of transplant's relatively low, then sooner rather than later is best. Whereas if the risk of transplant is high, or if the scores are kind of intermediate, then in terms of risk of the disease, then it may be better to wait a bit and try a treatment like ruxolitinib to see if things stable out and then do the transplant a bit later. And by a bit later, sometimes we mean later time-wise, or sometimes we mean if things aren't going as well as we would expect with the ruxolitinib, then that would be the time to think about it. But again, it's very individualized. So for treating myelofibrosis, one of the cornerstones of treatment are these JAK inhibitors. And for years, we've had ruxolitinib. Great medication, works really well to shrink the spleen and help with the symptoms. The biggest side effects is it can lower the hemoglobin and platelets too much in people with myelofibrosis. We also have in BC another medication called fedratinib, which is also a JAK inhibitor. It's not widely used because it's got more GI side effects, so like nausea, diarrhea. And it's similar to ruxolitinib, so it's not really better than ruxolitinib. So we would generally go with ruxolitinib first because it's got less side effects and works just as well. But sometimes if in theory, if ruxolitinib wasn't working, could think about fedratinib, but in BC, it's only funded if you're intolerant to ruxolitinib, so it's a bit difficult. The other next one that's just become available, like in the last couple of months, approved by Health Canada, is called momelotinib. So this is also a JAK inhibitor, but so it does to some extent the same things as ruxolitinib for helping with symptoms, shrinking the spleen, but it's got some extra activity inhibiting ACVR1, and because of that, this is involved in that iron pathways, and it tends to not bring down the hemoglobin as much. So it's a better choice for people who have anemia because it's less likely to drop the hemoglobin, and sometimes it can even bring it up. So this would be the right medication for people with hemoglobin under 100 who need a JAK inhibitor for treating spleen and symptoms. And then with the anemia that so the low hemoglobin we often see with myelofibrosis, options are erythropoietin, which is an injection medicine that stimulates the bone marrow to make more blood. And we sometimes use this in combination with ruxolitinib, so we can use the two of them together. Danazol, which is not as commonly used, it's related or similar to testosterone. The momelotinib medication, which can be helpful if there's another reason, and then transfusions if needed. That's very reliable, but of course, you have to go to the hospital to get the transfusions, and they only last about a month, and then people have to come back for the transfusions again. So again, just briefly to highlight some of the other medications that are coming that are not here yet. So there's a medicine called luspatercept, which is used in the related well, not related, but the other blood condition, myelodysplastic syndrome, to bring up hemoglobin. We're going to have a study with this at St. Paul's for people who are with myelofibrosis who need blood transfusions, combining luspatercept and momelotinib. There's another group of therapies called BET inhibitors, which are pretty advanced in clinical trials, but not yet approved. They block another part of the signaling pathway, and the trials use them in combination with ruxolitinib for newly diagnosed myelofibrosis patients and single agents later. So we'll be hearing more about these. I have a clinical trial with one. And this is another one, another type of molecule. There are all sorts of different mechanisms of action. So this is another one in trials. And then this is another trial that we have or will be opening soon, which again inhibits another part of one of the pathways that's overactive in myelofibrosis. And this is for people where ruxolitinib is no longer effective. And then the other exciting area that will be coming in the future has to do with CALR. So when people have a JAK2 mutation, the mutant JAK2 is inside the cell and affecting the signaling pathway. But if you remember from my original picture, the mutant CALR sits on the surface of the cell. So that means it's a potential target for some of the antibody therapies. So there is an antibody against the mutant CALR, which is in clinical trials in the US and at Princess Margaret Hospital in Toronto. And then there's also a version that's a bispecific antibody, so a newer type of therapy that has an antibody against CALR linked to another antibody that causes activation and cell and brings in other cells to cause cell death. So that's really exciting. And then you may have heard in the news about this CAR T therapy, which is used for people who have lymphoma and multiple coming from multiple myeloma. And they actually do CAR T treatments at Vancouver General Hospital for lymphoma. Well, they're also working on developing a CAR T for people with the with the calreticulin mutation, but it's not even in humans yet. It's just in the lab, but they're working on it, so the very early stages. So it's possible that down the road there might even be CAR T treatments, but very, very early days. And then finally, just to wrap up, I also got a question about about what we thought or what I thought the impact of tariffs might be with the changing in the global economic situation. So hopefully, and I'm not an expert in this area, but I'm hoping that it won't have a big impact on drug supply. So most drugs are manufactured outside of Canada and shipped in. So it'd only be if Canada started putting up some tariff walls, but it's so I am hoping that won't happen. Um, the second part of the question was about research, and this is a really good point. So it certainly is true that a lot of the research in this area is comes out of the US, and that there definitely have been some changes in research funding in the US, so that may impact things down the road. It's a bit harder. The clinical trials are mostly funded by pharmaceutical companies, so it will be a bit more complex to know how that's going to be impacted. But it certainly is possible that we may see some impacts down the road, but difficult to predict. All right, so that's all I have. I think I got my timing okay there, Mark. I wrapped up here. I didn't want to go too long.
Thank you very much, Dr. Foltz. It was a wonderful presentation and covering a lot of aspects of the illnesses and treatments. Thank you.